electrophysiologists heading the team in Sunnybrook at Toronto, and trained quite a few electrophysiologists in this field. Sheldon, happy to have you here.
Thanks very much. And thanks to the AV team for letting me use my laptop. I've seen everyone have to deal with the slide advance, so I wanted to do this myself. And first of all, Deepak, it was a fantastic talk. My charge is to talk about fluoride-free ablation, which is high-tech, a lot of money spent, and I don't know if it'll be done in the Indian setting, so please forgive me, I was not given this talk. So my objective is to talk about a fluoroscopy-free approach using the pulse-select system, and this has been my approach since I've adopted the catheter. You may ask yourself the question, why do you want to use no fluoroscopy during these procedures? Well, obviously, when we do these procedures in a cath lab, there's radiation exposure to you, the physician, there's the radiation exposure to your lab staff, and there's radiation exposure to your patients. These days, we've decreased the number of minutes that we use for fluoroscopy, so it may not be a big deal, but the bigger deal is musculoskeletal injuries. When you wear lead on for a long period of time, it hurts your back, you're just tired. And it's not only you that wears that lead, but it's your nursing staff as well. And you want to have happy nurses to do long cases in the lab. But the other reason to think about this is, whatever costs you get by spending on a 3D mapping system, you may save it in the future when designing future EP labs. In other words, there are huge fixed costs with fixed C-arms that you need in X-ray systems. By avoiding those X-ray systems, you can save some money and have the portability of taking your procedures throughout many places in your hospital or even different jurisdictions. So I'm just going to skip here to a quick video. Give me 1 second here. So I'm just going to play this video here for you to kind of show you how I do this. So, when I use the pulse-select system in no fluoroscopy, I use the NAVIC system. I first start by making a cursory geometry of the right atrium. One second. Perfect. So I first start by making a cursory geometry of the right atrium. I take the decapolar catheter and just put it up through the IVC. And as I start getting into the right atrium, I'll see right atrial signals. And I spend some time trying to make this geometry, because this kind of helps me when I do my transseptal access, but it also is just a good way to kind of get a feel for the heart and where things are at. I put my CS catheter in, and I use a CS catheter for all my PFA cases. Some of my colleagues in Canada stop using CS catheters, but the reason I do it is because when you get vagal episodes in AV block, I want to be able to pace. I do a lot of these procedures in older patients, and I find pre-treating with glycopyrrolate's a big deal because they get urinary retention. I can't send them home the same day. So having the CS catheter helps me understand when I have AV block, helps me understand if during ablation I've gone into atrial flutter, and it helps me pace if needed during the procedure. So once I put that CS catheter in, I try to get it into a ventricular branch, and then my next step is to do a transseptal. So I use ICE for transseptal access, and it's very helpful to do this. You take the view where you look up into the SVC, so you see the left atrium here, this is your SVC, and you do that by retroflexing the catheter and turning it leftwise, and you can place your wire up into the SVC. You can then trap your sheath up into the SVC. But what you can do as well is you can do your 3D, you can show that wire in your 3D mapping system by taking an alligator clip and putting it on the tip of the wire, and you can see that wire go up. So you have two cues, both the ICE and the 3D mapping system, to know that you're in the area of the SVC. Once that's done, we get prepared to do a transseptal, and we typically use a radiofrequency needle, and with that radiofrequency needle, you can show the tip on your mapping system and can help you drop down. Of course, we're using ICE with this as well to see us drop onto the fossa. And when we get onto the fossa in a good spot, then we pop a buzz and puncture across. So just let this play here for a second. Again, the 3D mapping system alone doesn't help you with the transseptal. Just make sure that you know that you're dropping the needle as you're moving forward. So again, we use an SL1 with RF needle. The reason I like to use the SL1 is that the sheath that we use to deliver the pulse select system is 14 French outer diameter. So by starting with a smaller 8 French hole, you have less of a resistance when getting that bigger sheath across into the left atrium itself. So there we're tenting on the left atrium, you see the needle, tenting on the fossa, then we buzz across, then we put our sheath across, and then I do a wire exchange for the flex cath contour. So again, this is 14 French sheath, so I want to make sure that when I put the sheath across, I have my eye on the septum itself. So we have the wire in the left atrium, and then I start putting the sheath across. And I'll just go back one more time just to show you one of the things that concerns me. Whenever I'm putting that sheath across, I'm looking at the fossa itself, because you get this tension on the fossa, as you can see right here. And you want to make sure you get that smooth transition on ice, so you don't get sudden recoil and go through the lateral walls of the left atrium. Then I put my PV tracker in, and I put my system into the heart. The PV tracker goes into the LSPV, which you can see on ice. And then we put the pulse select catheter into the heart. We do the usual steps to get the catheter in. And you can see the catheter coming out easily on ice. And as you do that, you can move your slider handle to have the catheter come out in the usual position. You know, when I first started doing these cases, I took the pulse select catheter itself and I made the geometry of the 4 pulmonary veins. I don't do that anymore, I do 2 at a time. And then what I also do as well is I use the alligator clip to show the tip of the wire, so I know where that walk guide wire is. And you can see that on my mapping system here. The little thing, which is D, is the guide wire. I tag electrode 5 because that's the most forward-pointing electrode on the catheter, and then as I move around, my mapper takes points where electrode 5 moves. And I go from vein to vein, and I try to move my catheter a quarter turn or so at a time. I do the ostium and the antrum. And to be honest with you, because this catheter is very safe from a hemolysis standpoint, and a thermal footprint standpoint, we tend to put more than just the usual 8 lesions per vein because we want to have durable pulmonary vein isolation. Typically start with the left veins and then go to the right superior. That can be a bit tricky because you now turn 180 degrees to get across the right vein. But it is something which is easily doable without the use of any fluoroscopy. So there we're in the right vein, we're doing the right upper veins, we're inside. And then this is a real video, so I flipped out of the right vein into the left atrium. I was able to get back in with my wire. And in all of this, I'm looking to see that the wire is always ahead of the catheter itself, as you need to see with the system. And then once that right superior is done, I then turn to the right inferior. And I'm always very careful with the right inferior because you can lose your transeptal axis when you're doing this, particularly when you're not using fluoroscopy. Just fast forward a little bit here. So now we're going to the right inferior, and again the ostial lesions and the antral lesions, and we're just turning the catheter as best as we can, quarter turn at a time. And then when the case is done, we remove the system. I'll just fast forward a bit for the sake of time. I do a lot of lesions, as you can see. So, we use ice to help us during the procedure. This is an example of the pulse select sitting in the left atrium. It's very easy to see. The left veins are very easy to visualize in the from looking from the right atrium. You can see you're sitting at the ostium there. Then you're in the LIPV here. Just getting there. It's very easy to see that you have some contact. RSPV is a tricky vein to see. You have to retroflex the catheter as you turn it towards the right side, but you can see when you're in the ostium of that vein. And the RIPV is a very easy vein for you to see with ice. You just turn the catheter 180 degrees and you can see yourself inside the inferior vein. Ice images aren't always perfect, and when you repurpose catheters, you often don't get great images, and this is an example of a fuzzy case, but the bottom line is that you can actually still do this relatively well with a combination of a 3D mapping system. Now, the one thing I learned in one of my first few cases without using fluoroscopy is that you can get this complication where you knot the end of the catheter, and I didn't know about this, my Medtronic reps didn't know about this either, and all of a sudden at the end of the case I couldn't pull the catheter out. And the reason why this happens is that there's a nose of the catheter which is in the middle, and that can pop out of place. Now that should not happen if you're leading with the guide wire the entire time. And that was my mistake. I moved the catheter around in this case with the guide wire in. So what I always do is I always make sure I can see the tip of the guide wire ahead of the catheter at every point when I move the catheter inside the heart. And then, when you remove the pulse select, you want to put the catheter into the left superior pulmonary vein. You want to get the wire far out and then slide it back in. And as you're sliding it back in, what you'll see is the catheter should straighten out nicely. If the tip, the electrodes 1 and 2 don't straighten out, then you know you have a knot and you're in trouble there. So I'm just going to quickly switch, and that's how you can see as you're pulling the catheter out there. You can straighten it out, it's straightened out nicely, then your wire comes afterwards. So I'll just quickly go back to my PowerPoint here. So we've done a bunch of cases with this here. This is just my first 30-something cases back in 2024 when we first started. Procedure times aren't excessively long. They're about the same most of the time as my colleagues who do this with fluoroscopy. And they do get shorter with time as you get over that initial learning curve. The LA dwell time is probably about an hour for us because we tend to spend a little bit more time in the left atrium. I don't rush in these cases because I want to get durable pulmonary vein isolation. But you know what? This is very, it has a bit of PTSD when you hear this sound bell. But what's happened in our experience is that the number of applications we place has gone up with time. And this just tells you that you can do this procedure safely and deliver more lesions and attack the posterior wall without the need for fluoroscopy. A question that comes up if you look at a lot of videos from these high-volume US operators, they talk about putting ice in the left atrium. I don't think that's needed. The pro is that right atrial ice is very simple. You put it in one position, you just spin it around 180 degrees. The con is that you may not get perfect visualization of the right superior pulmonary vein. The pro with left atrial ice is better imaging, but the con is multiple. First of all, it's a few extra steps, and these extra steps, when you're not using fluoroscopy, actually does take a little bit of extra time. There's an increased risk of iatrogenic ASD because now you have 2 big sheets going through one hole, and it still is only 2D imaging, so it still is relatively limited. So in conclusion, fluoro-free procedures with PFA, they're feasible. Right atrial ice, I think, is sufficient. And just in the case of pulse select catheters, be aware of knot formation. And I think, one of the things when you're doing these fluoro-free cases is knowing what technology you're using and knowing the safety and flexibility you have. I truly believe that, the thermal footprint and the low rate of hemolysis with pulse select allows me to place more lesions to get durable PVI. That's it. Thanks very much, everyone, for your attention.